So I'm going to share my screen. So is my screen visible and is it full screen? It's not full screen yet. Is it full screen now?
Yes.
Yes, it is.
Okay, fantastic. Okay, so I just want to make somebody the gatekeeper. So Manju, can
Sure.
I make you co-host so that if you
Yeah,
see anybody in the waiting room,
sure, sir. I will do that.
that's very kind. Manju, I won't always nominate you, so don't worry.
Thank you, sir.
Yeah, so Manju's co-host. We just have another thing. Good day. Please, I will not be able to record. Thank you. That's great. So let's make sure. Okay. So what is peer review? So peer review is basically a really good way of us being able to assess, look at scans, be able to kind of quality assure that the scan kind of, from our perspective, captures the images that we need. But more importantly, as I said to you, what is really important when we do peer review is the ability to be able to clinically correlate. So what I'm showing you at this particular point really is a slide of a 24-week baby who is 34 weeks corrected. And I'm going to take you through the coronal views. Now, as I've told you, whenever you start, you always start with the midline coronal view. So if you just look at me and you look at my head, really what I'd be starting is with the midline coronal view, as you can see, with the probe. And I'd keep it in the midline to obtain the midline view. But as soon as I've got my right midline view, then I'm going to angulate my probe anteriorly and basically then push it gradually to the back of the screen to basically ensure that I can actually get 6 coronal planes. So, anybody, any comments over here? Anybody? You can unmute yourself.
Yeah, this is here we can see that there is cavum septum pellucidum. Then
Yeah. So, what
it's
does
in
that
the
make
first
you feel?
the we can see the interhemispheric fissure in the middle, in the midline on the top part.
Yep. So, you can see the interhemispheric fissure. Actually, you
Mm.
can see the cavum septum pellucidum. You can
Mm.
see the orbital ridges,
Yes.
frontal bone.
Then carpus callosum in between the two.
Hmm. So, once you start seeing some of the corpus callosum in between, is this the first image?
No, it is not the first image.
You're
This is
right.
the
It's the
midline
second
one.
image. So
Second
actually,
image.
just for your knowledge, when you read, there's an article that I've shared with you, which has basically been authored by authors and published in Jove, and that gives the standard protocol. And their standard protocol is actually to start with the frontal horns. In this particular situation, because the ventricles are really slit-like and small at this particular point of time, really what you can't see is any of the frontal horns. And we've actually gone between the second and virtually the third image. So when I did this image, I really struggled with this baby because he had a very small, very narrow anterior fontanelle. And I was doing the scan on my own. So just capturing the image, I actually missed out on the first and kind of I'm somewhere second to third image because I can see the cavum septum pellucidum as you can elucidate over here. And really what I'm starting to see is a little bit of the corpus callosum, but I can see the frontal blush. And because this is such a small fontanelle, so anybody, which probe am I using?
Curvilinear
Conver.
probe.
Curvilinear
Yeah,
probe.
so it's a
Curvilinear.
curvilinear probe. Beautiful.
Curvilinear, yeah.
So you can see the curve over here when I'm using the curvilinear probe. Now let's just critique this image. So when we look at this particular image, is it good? Is it bad? Is it okay? Feel free.
Okay.
Okay. Thank you, Deepak. Great. You're absolutely right. It's okay. I mean, at this particular point, what it says, smallness of the fontanelle means that I've got a lot of dropout that's coming in the lateral fields. So when I talk about dropout at this particular point, I'm just going to annotate over here. I've got dropout in this region. So actually, it's quite dark over here, but actually it exaggerates my frontal blush a little bit. But really for a kind of a frontal image, I am getting a lot of the frontal hemisphere. I'm getting the orbits. I'm getting some of the frontal bone, cavum septum pellucidum, and the corpus callosum. Now, this is obviously a follow-up scan. So because this is a follow-up scan, I'm reassured that I've done a previous image, which basically has captured the structures more frontally and they actually look normal. But as I move back, what you'll see is really what I'm coming to is the third image where you have the cavum septum pellucidum and the ventricles starting to appear with the corpus callosum. And then you've got basically the temporal horns starting to appear over here with the interhemispheric fissure. So kind of proper third image. And really what stands out quite well to me is for a baby who's 24 weeks. I mean, this is pretty decent actually at this particular point in terms of the growth of the brain, in that it fills the screen. Anything else about the critique? So we talked about dropout. Any other critique?
Well centralized?
Sorry?
Centralized properly? Well
It's
centralized?
centralized properly. It's symmetrical. So I've got virtually 50% of the image on the other side. But one of the things that again I would talk about is, can you see the depth? And we talked
Depth,
about a
yes.
depth of
It's
about 6
8.
centimeters. So there's the option of us going in a little bit more. And I've always said that your image should kind of fill about 3/4 of the screen. So we can increase the depth to about 6. And in order to basically get more lateral gain, what I need to do is basically in the upper part of the image, I can change my time gain compensation to basically make it a little bit brighter, increase the return of signal from these areas, which will give me a little bit of a more uniform appearance. As we move back, can you see how, the anterior part of the fontanelle is very narrow? So actually my probe is struggling. But as I move back, I actually start getting more of the cerebral hemispheres and I can start seeing tissue a little bit better. Again, still with a little bit of dropout. But as soon as I move further back and I go into the midline, what can I see over here? Anybody?
Also in the midline intrahemispheric fissure,
Yep,
then corpus callosum,
yep,
septum cavum septum pellucidum,
yeah,
and the tertiary ventricles,
yeah,
and after tertiary ventricles the aqueductus.
yep. So the third ventricle is visible, and actually it's a little bit better visible over here in that these ventricles are very small. They disappear a little bit, but getting that view where normally the lateral ventricles would communicate with the third ventricle is not easy because actually this brain is now quite mature. You can also see the lateral fissure, as some
Is
people call it, or the
Sylvian
Sylvian
fissure?
fissure.
Sylvian fissure.
Yeah, as a Y coming through over here. And this is the image just before it again, just for comparison. But then I go into what is called the trident view. And in the trident view, what you see is that the cavum septum pellucidum and the third ventricle, they've actually disappeared. And really what you've got is you've got the lateral ventricles, again, a little bit of the Sylvian fissure on the lateral side, and you can just see some amounts of choroid plexus starting to appear. And then if you move further back, you get the trigone. And the trigonal region basically gives you the choroids, which look decent, bulky. Uh, what do we think about the brightness of the choroids?
Hyperechoic.
Okay. So we'll talk about that in the next class.
Looks normal, like a normal choroid plexus.
Okay, somebody said normal, somebody said hypoechoic. We're not going to talk about it today, but we'll talk about how we interpret choroidal brightness in the next class, because I'm going to show you some immature brain images in the next class. But this is the trigonal view. That's basically what we call as normal flare. It's basically like a blush. It's kind of triangular in its appearance to the lateral side. There are no cysts at 34 weeks at this particular point. And as the fontanelle is wider towards the back, I get much better, you know, brain visualization. Actually, the sulcal gyral appearance of the brain is visible to the point where actually I'm just towards the back of the brain starting to see a little bit more extraaxial space. So if I just annotate it, this is just, we're heading towards the back of the brain now, and there's a lot of extraaxial space. And if I actually move towards my last image, you can see actually that there is an element of extraaxial space that's quite wide. So it's just indicating that the back of the brain is not growing as well as the front of the brain, and that there's space here for this baby to kind of grow. And with growth, it'll gradually mature. Now, depending on how good your scanners are, you may or may not be able to pick up extraaxial space. This is basically a frequency of about 6 that I'm using over here at this particular point. So I'm getting quite good depth. I'm getting quite good penetration, overview, and actually quite good delineation of the tissue. These are not, so some people sometimes confuse this and think, are these cysts, these bits over here? They're not. They're just sulcal dropout that you see at the back. They're not cysts. It's actually the normal appearance. So just to say, just because I don't want to take your thunder away, because we've got a few people to present today. So this is the midline view. What do we think? Anybody?
Mid-sagittal view.
Mid-sagittal view.
Yeah. Good, bad?
It's good.
Yeah, it's
The
decent.
resolution laterally is not good.
So it's very bright in this area, and I have high gain settings. So what I've done is basically I have reduced time gain compensation in the upper part of the image. And that actually brings out normal sulcal gyral appearance. But some people might think that this image on the right is very bright and there's something going on over there. There's not. It's just that, as I told you, when you kind of use a certain frequency, the superficial tissues will appear brighter, more delineated, because I'm using what is a lower kind of a frequency. So it's giving me good depth and penetration, but these superficial tissues look a little bit more bright because of slightly higher gain and reflection from them. So by just adjusting time gain compensation, you can see the image on the left actually looks more normal. But what I've classically got is the corpus callosum right up till the anterior commissure. This is the ventricular communication. This is basically fourth ventricle. This is ventricle communicating third ventricle. This is vermis, and this is cerebellum. So it's pretty okay kind of a view. And then really when I move towards the left, the baby starts moving and I'm doing the scan on my own. So I really struggle to open the lateral ventricle up. I get a good image here. You remember, these are slit-like ventricles. It's never easy to see ventricles when they're really small, but I'm getting virtually the whole of the C here. And then I'm moving out towards the cortex and I'm getting bulky choroid over here. So I don't get them all in one plane, but together with 3 images, I get a good feel of there's no bleeding in the chorothalamic notch. And actually the choroid over here looks isoechoic. It looks okay. But there is a little bit of striate vasculopathy. We'll talk about that. So looks well grown, looks like a normal image. This is the outer image on the left. Similar images on the right. Now, one comment, anybody, can you tell me what's going on with that image on the right?
There is some flaring in the
Okay,
lateral
so
ventricle.
there is flare that's visible in this region, and there was flare that's visible there. He's a preterm baby, but he's 34 weeks and there's no cysts. This is really just frontal blush. But I haven't opened up the C completely of the lateral ventricle on this right side. It's somewhere between the midline because I can see the corpus callosum on this side. And it's because the baby's moving, it's difficult for me to keep the baby's head in the midline. So I really struggle to open up that C. But actually, when I looked at my coronal views, I didn't see anything that concerned me with regards to hemorrhage. So I've settled with these images. This is the right lateral, uh, very
Yes.
parasagittal view, cerebral hemispheres with the temporal lobe, as you can see over here. This is what fissure?
Sylvian fissure.
Yeah. And what is this called? All
Temporal.
the insula.
Yes.
Okay. So I've shared all these images with you, but I am now keen, having shown you some of the anatomy, for you to share images with me. So I've enabled sharing for all of you. So what we're going to do is we're going to start with Kunal. Kunal, are you able to share?
Yeah, I will share. So
Lovely.
is my screen visible?
It is.
It is. Okay. So I am so sorry I was not able to prepare the PowerPoint, but I have my images and little
Yeah,
bit
no
of
problems.
history. So I would like to begin with. So I'll present a brief history. So this is a 33-year-old Gravida 4 para 2 mother who delivered at 38 weeks, and she had an uneventful antenatal period. All anomaly scans, growth scans, NT scans were normal. She had a spontaneous vaginal delivery on 17th of March with a male baby weighing 3.85 kgs.
Okay.
So it's what I have done. I have tried to do a scan of a term, cranial scan for a term newborn.
Okay.
So, Dr. Alok, can I ask few things?
Yeah, please.
So first thing what I struggled with, so in our USG machine which we have in our unit, they have a preset settings for cranial scans,
Yeah.
which is displayed at pediatric abdomen over here. So in that, the frequency I could see it was pretty high. So I wanted to bring it down, but I could not figure out how to do that.
Was there a button
So
for frequency?
there was no button for frequency, and when I tried to change the setting, then the system was telling me that it will restore to factory default. So I could not do it. I think
Okay.
I will get
So,
back with biomedical to check how to alter the
sure.
frequency.
Can you send me a screenshot after this? PM me. Don't put it on the group.
Okay,
Just private message
okay,
me. I need to see your board, your motherboard, and
okay,
if there are screen buttons, I need to see them, and then I can guide you.
sure.
But just as a start, this is not a bad image at all. I can
Mm,
see really nice frontal lobes, orbital
mm,
ridge. I can see the orbits, and I can see a very nice interhemispheric fissure with
mm,
the frontal sulcus. It's beautiful.
mm,
My only comment is that you're 10 centimeters in, so your image can
mm,
actually fill in a little bit more. In
mm.
terms of your
Okay,
gain settings, this is perfect. I wouldn't worry
okay,
at all. Depth is the only thing. And
that
your pediatric abdominal probe, I mean, can I just say,
it.
I don't think you're
Yeah.
using the wrong frequency. How do I know that? So
Mm.
I'm just going to annotate your screen if I can. Can you see my cursor?
No, I can't see
You can't
your
see your
curse.
cursor. Okay.
Mm. No, because I am on the another page, that's why probably. No, I cannot see the
Okay.
cursor.
So just when you look at the screen, this is really important for everybody who's here. Can you come down? So open your image.
Yeah, I am just
So I want you to come down to the extreme left where you see a triangle 5 to 8.
triangle. Yeah,
Yeah,
this
that's
one.
so you're actually using a frequency of about in between, which would
Five
probably
to
be
eight.
about 6 to 7. That's okay.
Okay. Okay.
That's perfectly reasonable.
I thought this was the frequency, 35
No, it's
hertz.
actually the arrow. That's no, that's not accurate. That
Oh,
basically you will never be able to achieve a frequency of 35 hertz.
okay, so
Yeah,
that okay,
the highest
probably.
frequency probes are about 20 at the moment. So
Okay,
your
okay.
frequency is between 5 and 8. It's probably about 6
5,
to
5.
7. That's okay. That's
Oh,
perfect. Carry on.
oh. So this was the coronal view, the first image showing the frontal lobes and all. Then
Beautiful.
this is the second image with the Sylvian fissures and the we have just reached about to see the this part is the cavum septum
Yep.
pellucidum, the interhemispheric sphere.
Yep.
Then next image here we can see clearly the corpus callosum, and these probably is the two horns, frontal horns of the lateral ventricles.
Yep. Can I just say very good gain settings? Very good. You don't
Mm,
need to use time gain compensation over here. Very good
okay.
gray white matter differentiation. I can see the sulci very well. There's a
Mm,
chapter that we're going to do, which is interpretation, and you always move from out to in. Beautiful image. Nothing for me to say. Well done.
mm. Beyond this, now it was getting a little difficult. In the this part, I think this is the this is the prob. I'm not able. This is the Sylvian fissure which is
Yep.
disappearing right now.
Yep.
This is the third ventricle.
That's correct.
And probably here is the cerebellum.
Yeah, it will gradually come into appearance. You're
Yeah.
right. Temporal lobes, and then you've basically got the cerebellum that'll come into view. So just again, it's a beautiful image. My only comment is, can you imagine if that was a little bit bigger? If you had more depth on that,
Okay.
and if you were
Okay.
filling about 3/4 of the screen, so you want to reduce
Okay.
that 10 of depth to about 7.
6, 7. Okay.
Okay,
Okay.
but
Okay.
rest of the image looks beautiful. It's a little bit blurred, and the reason it's a little bit blurred was the baby moving at the stage.
Yeah, baby was moving a little bit.
Yeah.
Yes.
So
I
what
have
I'd say is, if the
taken
baby
again.
moves and you freeze an image, move the ball to try and get the
Okay.
best image quality.
Okay.
Okay,
Okay. Okay. Okay.
well done. Carry on. Yeah.
And this is we have reached the posterior most, the occipital area
Yep.
now.
So just for all of you at the back, that dark area at the bottom where your arrow is, that's the cisterna magna.
Okay.
Cerebellum with cisterna magna starting to come into view. So again, you basically have a moving baby. So just remember, if you freeze and you're getting an image that's blurred, move the ball. The ball will basically help to optimize images. But if you get an image like this, you almost will have to repeat it because you've got a significant amount of blurring on that left side. But well done. Well done. Amazing. Carry on.
This is now the sagittal
Very nice.
in the midline. This is the midline sagittal, mid
Yep.
sagittal. Then here we can see the corpus callosum.
Beautiful. Beautiful.
Then the gyri and sulci we can
Yep.
see.
Very nice.
Then
Carry on.
this is going towards the right parasagittal.
Yeah.
Then tangential parasagittal, more
Yep.
angled sagittal. And this is the left side. Can see little bit of slit-like ventricles over
Yep.
here and the caudothalamic groove.
So did you do the scan on your own, or did you have a nurse help you?
Nurse was holding. Yeah, it was two people doing the scan.
And was the baby
She
in a
was
cot?
baby was on a platform under the warmer, on a warmer.
Okay. Okay. Fair. Fair.
With
That's good. That's good.
some sucrose and pacifier.
Well done.
Then yeah, this is the most sagittal for the left side.
Yep.
Then I was
Well
just
done.
trying to take some pictures. And I have gone to the mastoid as well.
Okay, let's have a
But
look.
I don't know if they make any sense. It will come. This one was the left mastoid.
It's a good try. You have a very small mastoid fontanelle in term babies. It's very difficult unless you've got hydrocephalus and it's open. So you can see what I think is probably the third ventricle, and the cerebellum is very dark at the back.
This
So
one is the cerebellum.
you can see a little bit of the mesencephalon as well in the front. But well done. It's a good try. I'm really pleased.
This is another one for the left side. Then I tried both parallel and perpendicular one
Yep.
for the mastoid.
Yep. So you can see the third ventricle there.
Yes, this one, yeah,
Yeah.
I could figure. Then this was the right side.
Well done.
That's all, Dr. Alok, that's all.
This is
There are just
so
for
these are the temporal views.
yes, I was just trying to understand how to figure out, trying to correlate with the images that how cerebellum would look and how the fourth ventricle would look if you do the mastoid views and all.
Very nice. Very nice. So I'll ask you to stop sharing, but well done. My only comment would be the depth, and just the images being blurred because the baby's moving. My next kind of when we look at your slides again, I think the only two things that I want you to change would be the depth. Try to get it to about 7 centimeters. And some of what is happening, the blurring of the image, is probe stillness. You need to have, so I want you to practice holding the probe like this, 3 fingers, feeling the fontanelle. I want you to get a really good feel of the fontanelle, because when the baby moves, the idea is your hand should automatically move to try and accommodate. So,
Oh,
but very good, very good. My compliments, sir.
thank you. Thank
I
you so
I
much.
kid you not, I I never got as good at images. It took me weeks. So God bless you. I'm so grateful.
Thank,
And thank you so much.
thank you. Thank you.
So we've got Nora. Nora, would you like to share your images?
Can you see my screen? Can you see my screen?
Yeah, go for it. You can go to full screen. Beautiful.
So I'm presenting a turn baby whose growth was normal for the 38+3 weeker. The head was relatively large compared to the weight and the length. There was an antenatal diagnosis of ventriculomegaly, and for
Yep.
this reason, the mother had fetal, there was a fetal MRI done at 35 weeks, which showed bilateral ventricular dilatation, mild on the left, moderate on the right, and an abnormal vermis. Maternal serology showed CMV IgG positivity with high avidity at 36 weeks, and the mother was also IgM positive. And the baby surgery at birth was IgG positive for CMV, IgM negative, and the urine PCR was negative. And hearing blood tests were normal, and there was no chorioretinitis. Images, so I used the GE
So
scanner.
Nora, your volume is quite low. Are you able to put your volume up by any chance?
Yeah, is that better?
Go to as high as possible.
Yeah, that's the highest.
Okay, that's good. This is good. Okay.
So I used the GE machine C310 curvilinear probe for the standard views, and in my institution, we use the linear probe for the sagittal sinuses. So these are the first two
Very
images,
nice.
like the interhemispheric fissure orbiter and the frontal white matter, and then the second image with the anterior horns and the Sylvian fissures and the little temporal.
So beautiful images, beautiful images. Yeah, just again, depth. My only comment would be depth. We want to really get it down to about 7, but beautiful images and really nice great white matter differentiation. A little bit of dropout, towards, and that's the nature of the fontanelle. I suspect, was it a baby with a small fontanelle?
Yeah, I mean, not extremely small, but yeah.
Okay.
So we have the anterior horns, the corpus callosum, the third ventricle, and the little, like the cavum subparasitum is smaller compared to the case that we saw before. And then as we move into the fourth image, we can already see the cerebellum, and that
Yep. Cisterna magna at the back.
Magna is prominent. And then in the posterior regions, like the posterior horns of the lateral ventricles, the choroids, and in the most posterior image.
Yeah, because you have ventriculomegaly, the posterior horns a little bit dilated.
There were still, yeah, some posterior horns there. And in the midline, and the corpus callosum was complete. You can see the ventricles, fourth ventricle, and the prominent.
And just again, really big cisterna magna, again, because you have ventricular dilatation, so you have dilated extraaxial space. Yep, very nice.
In like we do Doppler on every baby. I mean, for this particular baby, the RI was 0.61, but the baby was not.
Baby as well, right?
Yeah, yeah. So
I wouldn't worry too much. The number in itself doesn't make too much of a difference if the baby is not with HIE, and so yeah, well done.
And then the parasagittal view. So this is the right. I mean, the posterior horn is very dilated. And I measured the thumb occipital diameter as 11 millimeters.
We'll talk about that.
And
Well done.
Similarly, on the left, I mean, sorry, so this was put on the PowerPoint, but like it's about 26 millimeters, also dilated. And then I had the mastoid view. So this was through the right mastoid.
Oh, you've got very nice axial views.
So if it's through the right, then this part of the cerebellum is the right cerebellar hemisphere. Is that correct? Yeah. And then the vermis and the left. And then there we can see the abnormal, like the megacisterna magna. And then there's the fourth ventricle. And then we look at the sinuses for every baby.
Beautiful.
For this, we use the linear probe.
Very nice images. There's nothing to critique over here. I can see that you're using the linear probe to get these images.
Yeah. Mm-hmm.
Yeah.
So that's all. Yeah.
Well done. Well done. So I can see that Abhijit has joined us. Fuad is not there. Who else? Who else was going to present today?
Yeah, I am.
Okay, Nashwa, you can share. And then after that, we will start Abhijit's presentation.
Okay.
Alok, just give me a shout once we are ready.
Sure, absolutely.
It is, you can see my image?
I can see your image.
Yeah, okay. This is 28 weeks preterm baby, 1.1 kg. When I did this image, it was at the age of 2 weeks old. He was on non-invasive respiratory support at that time. I did this image, and the quality is, I don't know, it's not good, but maybe because I taking a freeze and after that I take a photo from my mobile. So
it's perfect. There's nothing wrong with it. So for interpretation's sake, it's absolutely fine. Again, my only comment is everybody, you kind of depth is about 10 centimeters. You just want to make the image a little bit bigger. I want you to kind of practice putting your images into 3/4 of the screen. Maybe the gain settings a little bit high. Do you have an auto gain function?
Auto gain, no. There is a gain, the bottom gain, and there is time
This time gain compensation. So what I'd say is, for me, you might just want to put the overall gain down a little bit.
Okay.
Yeah, but otherwise the image is perfectly interpretable. It's beautiful. Yeah.
Okay. This is at the level of the anterior horn of frontal horn of the lateral ventricle.
Yep.
Just a minute, sorry.
Yeah, no problems.
No, sorry, because it is like images. Okay, this one you can see.
Yep, that's fine. That's fine. What I'd suggest is today I've given you a flavor of how best to share your images. And I would say a little bit of history, one line on the front slide, and then basically putting your images on the PowerPoint. And I would say between 2 and 3 images per slide. That's the best way to do it. Okay? But well done.
Okay.
Well done, Nashwat. This is a good image. I think take-home message for everybody today is work on the depth and play with your gain settings and time gain compensation, but very good images. God bless you.
Okay, and this is a tribune, and this is a most posteriorly.
So your images aren't moving.
Yeah, I am because you said topagid is waiting, and this is a mid-sagittal view.
Sure.
Okay, this is the one, and this is the lateral parasagittal.
Actually, Nashwa, the images aren't moving on the screen.
Yeah, I am. You want one by one because I saw you are.
So maybe what we
hurry.
can do is we can put them on a PowerPoint and you can start first next time. Okay?
Okay. Okay.
That's the best way because I don't want you to miss. So from my next session on Sunday, we'll be having 45 minutes of peer review and you'll be starting all of them. So by all means, any of you who've got slides, put them on a PowerPoint, one line of history, and try to get 2 or 3 slides per PowerPoint. So I'm going to hand over to Dr. Abhijit, who is a colleague of mine who has been working in Glasgow as a consultant neonatologist. And basically, I have learned a lot of point of care ultrasound, especially lung and heart from him. He's taught me a lot. He has got a special interest in point of care ultrasound. He's written books on point of care ultrasound. At the moment, he's doing a research fellowship alongside Dr. Neil Patel, who some of you might know, in Glasgow, and has done a lot of work on speckle echocardiography. So, without further ado, I'm going to hand over to Dr. Abhijit. Abhijit, you can share your screen.
Thank you, Alok.
And he looks handsome. He's a handsome boy. Yeah.
Oh, thank you for the compliment. Right. Right. Why am I struggling to share?
Yeah.
Right. Can you see my presentation?
Yep. Yep.
And the full screen?
And full screen. And you're audible.
Lovely. So good evening, everyone. Thank you, Alok, for your lovely introduction. So I'm not repeat the introductory bit. So we'll just straight away crack on with the presentation. So this is the hospital where I work in Glasgow, and Alok has asked me to give a talk on the use of the cranial ultrasound in HIE in units, and and the auxiliary imaging which we can do in HIE. Right. So looking into the neonatal brain, it was not a possibility until 1960s. I'm a big kind of my hobby is to read the medical history, so it's quite fascinating and quite interesting as well, like how we have evolved in terms of medicine as a whole. So looking into the neonatal brain, so it was not a possibility until 1960s, and then some wise men came up with the ultrasound. And proudly so, I can tell you that they were from Glasgow, working at the Royal Infirmary. And that was the advent of using ultrasound in medicine, initially with the obstetrics gynecology, and later on it trickled down to the neonatal medicine. Usually I like one-to-one, face-to-face interaction, but not a possibility here. I like to ask a lot of questions to make it interactive, but nonetheless, old habits die hard. I'm going to throw in some slides with the random facts and questions. So anybody knows this guy? Nope. Okay, so anybody knows this picture? Right, so this guy is Dr. Ian Donald, and this is the first ultrasound machine to get the image of the organs involved. So you can see the patient has to be submerged in water because ultrasound waves doesn't like air. So we use the the ultrasound gel to take that interface out. So this was a kind of a machine we started with, and now we know we can get a portable handheld one. So Ian Donald and his ultrasound scanner from Glasgow and from Royal Infirmary Hospital. So the cranial ultrasound was introduced in 1970s with the 2D ultrasound scanning to visualize the brain. Levin et al. Has published a paper in Archives of Diseases of Childhood in 1981 and concluded that the real-time ultrasound scanning allows the neonatologist to examine the newborn's brain and to do advanced monitoring with the better neurological assessment. And we have come a long way since then. Coming to the topic today's topic, so hypoxic ischemic encephalopathy, a brain injury caused by oxygen deprivation around the time of birth. Every one of us knows that. It's a bread and butter in neonatology, and the leading cause of neonatal mortality and long-term neurodevelopmental disabilities. And where do the cranial ultrasound comes in? It is a non-invasive bedside imaging tool for early diagnosis and monitoring and prognostication. A little bit of pathophysiology of HIE, and I'm sure all of you knows about this. The reason for showing you this pathophysiology slide is that the HIE has got three components: the hypoxia, where is the lack of oxygen; ischemia, there's the part of the brain which is not receiving enough blood, and leading to encephalopathy of that particular area. And it goes through multiple phases. We have a therapeutic window in the latent and the secondary phase, where there is cell death, apoptosis is undergoing, there's an inflammation, there's an oxidative stress, and then there happens a reperfusion, which leads to reperfusion injury, which basically leads to cytotoxic edema. And all of this has a contribution in what kind of image you're going to see when you do the cranial ultrasound. And that is the therapeutic window where you are doing the therapeutic hypothermia for these babies to kind of arrest the apoptosis for the inflammation and oxidative stress, basically reperfusion injury. And I'll explain it to you when I show you the images, what we see in the cranial ultrasound in HIE. What will be our approach to, in these cases? So knowledge of the normal developmental anatomy. So I'm sure Alok and other speakers must have gone through the normal developmental anatomy of this of the brain. We have to be good with our technique. It has to be correct, and the ability to identify the abnormal variants. Because there are a lot of normal variants as well. So it's imperative to know the one from the other. Then comes the correct interpretations, and in HIE, it's a dynamic changes in the brain that's happening. So the knowledge of the sequel is important, and there has to be an appropriate follow-up scans. And once you have done the cranial ultrasound, you have that's what you are monitoring, and then prognosticating. So you are prognosticating the parents and the colleagues. So the communication is again the vital part of it. I can see that Alok has been through all the the coronal, sagittal, and transfer cuts that we use to visualize the brain. So I'm not going to repeat all this part. I'm going to skip that. At the same time, at the onset, we need to be aware of the limitation of it as well. And there comes the role of the auxiliary scanning techniques. So what are the limitations? So myelination is not at all depicted in ultrasound. So it's very difficult to see myelination. Or rather, I would say you can't see myelination. There will be diffuse white matter injury when there is the interruption of the blood flow, ischemia, but that is not well detected with the ultrasound. You can see the surrogate markers of it, but you cannot see the diffuse white matter injury. Limited visibility, if there's a small window, it's always a challenge because HIE happens in the well-term born babies. Most commonly, it can happen in late pretermers as well, but most commonly in term babies where you already have a smaller fontanelles. So it becomes a bit of a challenge there. And you need the experience and the expertise to interpret the results and to manipulate the probe and the baby to get the right images to make those interpretations, monitoring, and relevant prognostications. So I'm just going to run through a quick recap. I said it's an essential recap because the normal anatomy is very important. So this is the brain development. So it starts with the primary neurulation where the neural tube is formed. It is folding, and it's the adjacent part which is going to fuse. It's going to oppose and fuse, giving rise to the neural tube, abutted by the neural crest cells. And there's early prosencephalic development, and there's a neural proliferation and migration. And you can see, it's quite a smooth brain until 6 to 7 months of age. Quite a smooth brain. We are right in this part, the preterm and the near-term newborn babies, where most of the time there's an organization that's happening. There's a lot of gyrification that's happening. So from a smooth brain, which has a very little surface area, so brain goes extensive gyrification, which is the infolding of the gyruses and sulcuses. And once the babies are born, then the myelination continues until the later ages. And you can see quite a gyral ensulcation in the term-born babies here. And this is important because when you're looking at the the changes of the HIE, you will be looking at the sum of this, the gyruses and sulcuses, and not being able to demarcate those things. So, and when the babies get hit by the HIE, the process that impacts is the organization and the myelination, and so is the problem of the cerebral palsy in these babies. Few of the cardinal sulcuses. So the central one, I'm sure you all are aware of it by now. I don't remember all of it. I'm not a neurologist, neither I'm a radiologist. So I don't remember all of the brain sulcuses and gyruses. I just keep track of few things. Of those are the central sulcus, and when you do a cross section, sagittal section, sorry, not cross section, you should be able to identify the cingulate gyrus, a bit of a protrusion of the central sulcus here, the calcarine fissure, and the parieto-occipital sulcus. As I mentioned, there is a lot of gyrification that happens, and you can see here as the pregnancy progresses, that's on your x-axis here, you can see on your the volume, there's not much of an increase in the volume of the brain, but you can see, they're depicted by the white dots here. The gyrification goes up in leaps and bounds, and you end up getting a very highly markings in the brain when you are doing the cranial ultrasound of the gyral and sulcal folding. It starts in the third trimester and leads to the dramatic increase in the cortical surface area. And again, this is just the schematics to show you how it changes over the weeks. And again, just to appreciate the fact that this is an adult human bringing extensive gyral and sulcal foldings. That's a newborn baby compared to mid-gestation baby here. Pretty much smooth brain, and you can see here by the time they are full term and born, you have gyruses and sulcuses, and that's the adult human brain. Okay, so when you're doing the brain, the cranial ultrasound, this is what you see in coronal view. And pardon me for doing the repetition here. I'm sure the other speakers must have gone through it. But nonetheless, I'm going to repeat myself again. So this is 23 weeker and working up all the way up to the 40 weeks full-term baby. You can appreciate the calcarine sulcus here is wide open. So this is the cross-sectional brain. And you can see this gap here. As the baby will be premature, there will not be much of a gyral folding. So you can see wider gap. And this is seen in the cranial ultrasound as this gap here, right? And as the baby grows, the fetus is growing, the infoldings are happening. So the gap of the calcarine sulcus comes down, and it takes a nice Y kind of a shape here. And also on the top, the cortical areas, you can see the markings coming in, right? It is not uncommon to see wide intrahemispheric fissure in the preterm babies. And later on, it becomes quite a snug fit. And the size of the ventricles also becomes more kind of a slit-like as the baby grows towards the full term. Again, I'm not sure if I should be repeating this, but it is self-explanatory. All the markings has been given here. We'll be focusing mostly in this part in HIE, and the changes pertaining to this area, and that's what we're going to focus on. So just to be aware that two lateral ventricles, right, interposed by the corpus callosum connecting the right and the left hemisphere, separated by the intrahemispheric fissure here. And just abutting the ventricles, you have the chordate nucleus and the lentiform nucleus. In between that, you have the white fiber tracks that is connecting the cortical areas to the midbrain and further down. So you can imagine if it is a white matter area, it is full of myelin. And I'll tell you why we need to know that, or what is the implication of that while doing the scan. Right. So with the brain development, do not forget the cerebellum. And I was glad to see that people are talking about the cerebellum, people are talking about the mastoid, because that is the view most people tend to ignore and not to do it. But according to the American Academy of Pediatrics, it should be done. And a scan is not complete if we have not seen the cerebellum for the hemorrhages or the ischemic changes. And just be mindful that cerebellum grows in leaps and bounds from 24 to 40 weeks. Its volume increases by 5-fold. So this is important bit. And I was glad to see that people are talking about the mastoid views. Just to show you the image of the cerebellum, and this is the mastoid axial view. Maybe I shouldn't be repeating it, but yeah, that's the mastoid axial view, and that's the coronal view, showing you the arbor vitae in the fourth ventricles, the dentate, and everything. Right, my favorite part, a slice of history. Again, anybody knows what this is? Any guess?
No idea.
No idea. Cool. So you'll be surprised to know that this is an ultrasound machine. In the sense, so that's the ultrasonic transducer, right? So piezoelectric crystals had been placed here, and they started using it as a kind of a portable ultrasound machine. From that big tub filled with water, this is where we reached, and this is from 1980s by Paul Rosenberg Associates in New York. So ultrasound machine. Moving on, so cranial ultrasound protocol. So protocol stays the same irrespective of what disease, what condition you're dealing with. So and I can see from the previous lectures by the speakers, they have discussed, all the coronal cuts and the sagittal cuts, the prime cuts, the 6 on the coronal, and 3 on each side in the sagittal. So not repeating that. Acoustic windows. Most commonly, we are used to anterior fontanelle. I have barely seen people using posterior fontanelle, but it gives us very useful information when you're dealing with hemorrhages or ischemic changes, again, which is a part in the HIE. Mastoid fontanelle, very important to access the posterior cranial fossa, cerebellum, and the temporal window as well. Also, the temporal window and mastoid fontanelle gives you the most accurate Doppler interrogation of the middle cerebral artery. When you're doing that with the anterior fontanelle, you're interrogating the anterior cerebral artery. For the middle cerebral artery, the angle of insonation is practically near to 0 degrees, so you get the best measurement out of it when you're using temporal window and the mastoid fontanelle. When we talk about the injury and assessing, monitoring, or prognosticating, MRI is the gold standard in HIE. It is the gold standard, and we always end up doing the MRI. But because of the technical challenges while baby is being cooled, it is really difficult to do a serial monitoring. That's where the cranial ultrasound comes in. But the gold standard will always be MRI. Talking about the injury, we have to know the blood supply and the vulnerability of these areas. Why those areas are vulnerable? Why do we see those changes there? So I'm sure you're aware of the concept of watershed areas. A very peculiar thing about the blood supply of the brain is that it is from outward to, from the outside, from the cortical areas all the way to the inside. That is not a problem. That gives you kind of a pattern where you're going to see the changes first. The problem is this vessels narrows down in caliber pretty quickly. So it's a wide vessel on the top, and then it becomes narrow in caliber very fast as it is perforating the brain all the way to the inside. And in some places, like the periventricular areas, you can see it hardly reaches there. So you can imagine these areas, the periventricular areas, where I have just shared the slide where I showed you the chordate nucleus and the lentiform areas and the tract of the white matter. So all those areas are already vulnerable because you can see that it is hardly reaching there. At the same time, these deep cortical areas are very energy consuming they do need constant supply of the oxygen. So you can imagine this watershed areas are vulnerable. When I say watershed areas, that I'm sure you guys know, but I'll just going to repeat myself. It is the area supplied by the two artery system. As it like, if I particularly talk about this particular area, it will be shared by the anterior and the posterior, anterior and the middle cerebral artery. So that's what the watershed areas means, and this is just a schematic representation of what I've just spoken here. Multicystic areas develops if you end up having ischemia and hypoxia in this particular area. And same thing, this is just I discussed just now. Watershed areas, this part of the cortical areas, again, this is a coronal section, lateral ventricles, foramen of Monro, and the third ventricle here. So this is ACA, purely ACA territory, MCA territory, ACA being anterior cerebral, middle cerebral artery, and this is the area shared by the two arteries. And you will see infarcts in these areas, ischemic changes in these areas. And same for this area, shared by the middle cerebral artery and the posterior cerebral artery. Again, the representation in a different cup. And you can see this is the area by the ventricles where you have the tract, yeah, and you have the chordate and the lentiform nucleuses, right? So just be aware this is a vulnerable area, perforating arteries reaching here, going down in their calibers, and quite a vulnerable area to ischemia and hypoxia. And this is where we see all the changes. So what is the pattern of injury? So when we talk about the hypoxic ischemic encephalopathy, so typical term HIE involves the watershed or the BGT. BGT is basal ganglia thalamic region at the deep cortical area. And there's an atypical term HIE which involves the cortical areas. We'll see what is the difference. So again, this schematic representation. So the typical term HIE is usually normal antenatal history. The pregnancy was absolutely grand, no problem there. But then there was some sentinel events in terms of the acute complications like the, rupture of the uterus or antepartum hemorrhage. It could be one of the sentinel events. The baby is born with a low Apgars, there will be significant acidosis. And this baby is because it is involving, you can imagine, the blood is not reaching. This is the part of the brain which will be cut out of the blood supply if you have that kind of a problem. So there will be a moderate to severe neuroencephalopathy in this kind of the term HIEs. Contrast to this, the atypical is less common. There is antenatal problem all throughout, in the sense grumbling problems. There will be maternal comorbidities, the diabetes, or hypertensive mothers, and there will be some kind of a grumbling problem throughout the pregnancy. But there's not a single acute event. It is more common in males and in IUGR babies. And in contrast to the typical term HIE, it is mild to moderate. It gets mild to moderate neuroencephalopathy, and it affects the cortical areas, the watershed areas. Right, the area shared by the, in this case, in this part will be the ACA and the MCA. So typical one, term HIEs has a higher mortality with 20 to 30% mortality rate, and more than 50% of survivors do get cerebral palsy because it is involving the white matter. Outcome depends on the severity of the basal ganglia thalamic region and the brain stem involvement. You can see this is a more deeper problem. The deeper nucleuses are involved. Whereas the other one, low mortality, mild CP in 5 to 10% survivors. However, because this is affecting the cortical areas, you have a higher prevalence of the cognitive impairment in these babies. And obviously that will lead to the behavioral difficulties, the visual problems if you are involving the area supplied by the MC and the PCA. And there will be seizures problems in these babies as well. All right. Right. Hope that I'm making sense so far. So what are the factors influencing the injury pattern? So severity of the asphyxia, duration of the hypoxia, and the gestational age. As I said, the HIE can affect the late pretermers as well. So it depends on what is the gestation of the baby, how long was the hypoxic event, the lack of oxygen to that part of the brain, and how severe was the ischemia. So all these factors will influence the injury pattern, what you're going to see in the cranial ultrasound and in MRI, and we're going to talk about that. So how do we assess? Again, anatomy and the maturation is very important, just to know the normal anatomy and the normal maturation profile of this the brain. Cortex and the gray white matter differentiation, that's what we want to look at, because it affects the cortex, the gray matter, and the white matter as well. So we're going to focus there to see if we can delineate those. Then we're going to talk about the periventricular and subcortical white matter. That's where we're going to focus again. We look at the thalamus and the basal ganglia. We do make some measurements like VI, which is ventricular index. I'm sure Alok's going to talk in one of his session how to do the measurements. Anterior horn width, AHW, and TOD is the thalamo-occipital diameter. And we do look at the subarachnoid space and the midline shift that happens because of the cerebral edema as a part of the pathophysiology of the HIE. So changes, don't worry guys, it's a lot of theory right now, but I'll show you the images. If you're getting apprehensive, I'm just going to talk this and finish it off. So what are the changes in cranial ultrasound in HIE? So there's an increased echogenicity. Now know this, when we talk about the increased echogenicity in ultrasound, you know there is some kind of a changes happening in the interface where your ultrasound beam is hitting and reflecting, right? If it is filled with water, it will attenuate, it just go fine, cross it. But if there is a change in, how do I put it? If there's a change in the medium, if there is something which is highly reflective, or between the two reflective surfaces there's water, any change in that kind of a medium, you will see increased echogenicity. Also, you will see periventricular hyperechogenicity. So you can imagine usually that area should be hypoechoic, but you do see hyperechogenicity. Why that happens? Again, the area becomes very, very reflective. There'll be loss of gray-white matter differentiation, which we call as a fuzzy brain. I'll show a picture of that. And basal ganglia hyperechogenicity. And because there will be a cerebral edema, your ventricle gets squashed and it looks more slit-like. You can barely see the ventricles in HIE. Okay, so loss of differentiation in coronal view. Just look at this image here. This is a normal baby, and this is quite, angling your probe to the posterior side of the brain, and you can see term baby because a lot of this gyruses and sulcuses. And just be aware that the sulcus in cranial ultrasound is reflective, and that's what gives hyperechogenicity. So the sulcuses. And why the sulcuses are reflective, if you're thinking, because your arachnoid membrane is making this infoldings, so that membrane is reflective. So when it's making those infoldings, your ultrasound beam's headed and it becomes quite reflective, and it comes as an hyperechoic structure in the scan. So normal here, whereas this is a case of HIE, you can still see some, but it doesn't look as sharp as it is here. None of this looks sharp in this particular image. So that's what caused the loss of, it looks like look of a loss of differentiation in HIE, right? And this particular, because it's all look kind of hazy and fuzzy, right? So when it looks hazy and fuzzy, no wonder you call it as a fuzzy brain. Okay. Again, this is to reiterate the fact that this is the particular area where we are focusing. Now, this cut is not exactly, this is not what we are seeing in this cut, but just be aware, this is the area we are focusing, we're trying to look at, and we'll come to it again. In sagittal view, again, the loss of differentiation, central sulcus seeping in, and then you can very clearly see the reflective margins here, right? Which is lost in this particular image. And again, because it is lost, it's called a loss of differentiation, right? In terms of the sagittal view, I was thinking of going through this anatomy, but I have seen that you guys have already been through it. But just to, one or two lines here. Singular gyrus is important, and the area adjoining to that particular area, singular gyrus, singular sulcus is the place where we're going to focus our scans at. So whenever you're doing a scan of an HIE baby, your focus, going back, your focus should be in this particular area, because in this particular machine, it does it auto, but nowadays we do get machines where we can change the focus where you are focusing. So it shouldn't be high up, it shouldn't be down below here. You should be focusing in the area of the interest. Make sense? I'm not sure if I'm making sense. So the basal ganglia area, the watershed areas, is where you want to keep the ultrasound focus on. Okay. We'll come to that again. Sagittal view again, and you can see a very sulcated brain, a lot of gyral and sulcal enfoldings. Can anybody tell me which one is normal, which one is abnormal in between these two? As in, like, which baby is suffering from HIE?
The one with the blue arrow marks is the normal one, and the other one is the abnormal, because
Excellent. And how do you make that difference?
ventricles look slit like in the other one.
Yes. Yes. And again, as I said, it looks kind of a hazy and fuzzy. The lines are not clearly demarcated if you pay close attention here. Whereas in this one, you can see nice, fourth ventricle. You can see clear markings, which you can't see over here. And yes, you're right. It's not exactly the ventricle over here. It's a cabum, but you can see that it's being squished. There is something called as plic, which is the posterior limb of the internal capsule. And it's quite a mouthful, but what that basically is the white, the white matter, the fiber track connecting the cortical areas with the midbrain and further down, right? So when, in terms of the anatomy, this is the part which is carrying a lot of myelin shape because it needs to transfer information. And myelins are very, reflective because it is made of fat. It has a reflective surface. So in ultrasound, it should be reflective. Whereas your basal ganglia and thalamic area should not be reflective because they do not have myelin covering on it. So in terms of the ultrasound language, your BGT should be hypoechoic, whereas your plic should be hyperechoic. And you can imagine if you have a HIE, it will flip, right? So you can see this hypoechoic green area, is your posterior limb of the internal capsule. Now, if you have a myelin sheath there, you should not be having hypoechoic area. Now, because that part has got the injury, there's an insult there, so it has gone down as an hypoechoic area. Similarly, your the basal ganglia area should be hypoechoic, but then there's been ischemia, there's been oxidative stress, the breakdown of the cell, there's an inflammation, and it has become reflective. Now we can see that part as a hyperechoic area, right? I hope that makes sense. And we will see more of that. This is just to show you the anatomy here again. And the caudate nucleus, this thin rim you can see is your the plic, and this is the part posterior limb of the internal capsule and the lentiform nucleuses. And same picture here. And this is the coronal. This was the coronal view, and this is the sagittal view again. And you can see the similar changes in the sagittal view. The plic has gone hypoechoic, which should be hyper, and the basal ganglia area has become hyperechoic, which should be hypoechoic. Next thing, in terms of the assessment of the HI, is the Doppler. And I'm sure you must be aware of how the Doppler works, so I'm going to skip all that part. I'm just going to talk what do we do with the Doppler in this cases. So we look at something called as the resistive index, and it's basically signifies the resistance of the vascular bed distal to the interrogated blood vessel. So the formula to get the resistive index out is the the peak systolic velocity, and what is the top velocity when there was a systole, minus the peak diastolic velocity divided by the peak systolic velocity again. So normal number is 0.5 to 0.9. If your resistive index is less than 1, you know that there's a forward flow during the end of the diastole, right? And if you have a resistive index equal to 1, then you know there is no forward flow in the end of the diastole. And if it is more than 1, there's a reverse of the end diastolic flow. All right, so this is all you need to remember. The machine will do the calculation. Don't bother about the formula if you don't know how to remember. You just have to interrogate and hit the resistive index button on your ultrasound scanner, and it gives you all the numbers. This is how we do it. So this is using the anterior fontanelle, Doppler interrogation, anterior cerebral artery. Again, whenever we are doing Doppler, the angle of insonation should always be less than 30 degrees. So why the magical number of 30 degrees? Until 30 degrees, the machine can make the pre-corrections. Beyond that, it cannot do it. So ideally speaking, it should be 0 degrees, but you can go up to 30 degrees. So the ideal place to interrogate, I don't know, straight a line from here, maybe here or here. Yeah. So that's where you interrogate in the from the anterior fontanelle for the resistive index. Right. If the resistive index is less than 0.55, that is again abnormal, and it's predictive of a poor prognosis in these babies. And then what can affect the resistive index in babies with HIE? Apart from HIE, what else that we do can affect the resistive index? Any guess?
Hypothermia.
Hypothermia, excellent. So that's the caveat there. So the baby, well, not if, we should be cooling these babies. So when you are cooling the babies, you cannot rely on the resistive index number. So it's prior to cooling, you can have some, a degree of, we can say with some degree of certainty what's the prognosis will be like. But once the cooling has been instituted, and you can imagine why that is, the resistive index is affected when you are cooling the baby is because all the vessels goes into vasospasm. Right, so when it goes into vasospasm, the velocities increases, and you will get a higher number. You're not sure if that's because of actually, the cerebral edema, or that is because of the therapeutic hypothermia that you are instituting because of the HIE. So as a gap, you cannot use that when you're doing the therapeutic hypothermia. So take that with a pinch of salt. Then, and again, do you guys want me to go through the cerebral blood supply, or you guys are happy? I'm not sure if you have been through the cerebral blood supplies.
Not yet. No, not Abhijit. Go for it. Yeah.
Okay. Again, as I said, I'm not a neurologist, so I don't care about all the vessels that we use. We are only worried about the vessels. Interested about the vessels that we gonna interrogate with the Doppler. All right. So this is the anterior cerebral artery. Guys, I beg your pardon. That's my little one maybe banging on the door. Please don't mind. I'll try to just um, right. So I'm interested in the anterior cerebral artery. That's across sagittal section of the brain. So anterior cerebral artery, the best window, acoustic window to interrogate the anterior cerebral artery is anterior fontanelle. Or on the again a sagittal view, the outermost part, the middle cerebral artery. Any guesses which is the window you're gonna employ or use to interrogate the middle cerebral artery? Anyone guess?
Temporal.
And yes, temporal is correct. Yeah, and
Mastoid.
yes. So you can see it is running through the the temporal lobe. So no wonder you're going to use the temporal window, acoustic window, and the mastoid window, where your angle of insonation will be practically 0 degrees, giving you the best number or the result. And this is a circle of Willis, and I'll show you the pictures of the circle of Willis. The reason I'm showing it to here is just to orient you with the vessels that all comes together. So anterior cerebral artery, you'll be interrogating that with the anterior fontanelle on top like that. Okay, middle cerebral artery, you can see you cannot interrogate from top because it's kind of a perpendicular, so you come from the side, so that will be your temporal or the mastoid view, acoustic window. And then you have the posterior cerebral artery. We do not use the posterior cerebral artery. I don't know, you don't have any windows down here to access that. And this is a slide to give you the cerebral arteries and the best acoustic windows to use. It's self-explanatory, and you'll have the whole presentation uploaded, so you can have a look whenever you're doing the Doppler interrogation of the vessels. All right. So this is how it looks when you are doing the Doppler of the anterior cerebral artery. This is the again sagittal section. This is how it looks in the ultrasound, and that's where we're doing the interrogation. Pick systolic velocity, pick diastolic velocity, and it does the calculation and gives you the resistive index. All right, and this is from the midline sagittal view. Similar thing here. Again, anterior cerebral artery from the midline sagittal view. This is how it looks when you are employing the temporal window. And here, this is the middle cerebral artery, and that's where you are coming from. So you can see that the angle of insonation is near about 0 degrees. So giving you the best possible estimation of the resistive index. So try to use the temporal window. Might be a bit challenging. This is always in the front of the ear and the smallest of all. If not temporal, mastoid will be your second choice. Well, I wanted to ask the question, but silly me, I can see that I have written the answer already. I wanted to ask which acoustic window I'm using here. So this is a circle of Willis, right? Anterior cerebral, middle cerebral, posterior cerebral. You can see a nice circle of Willis here. And I've already written it's a temporal one. So this is a mesencephalon here. And you can see the circle of Willis coming up beautifully. Right? Okay. Circle of Willis again. Now I'm using the mastoid axial view. Again, you see a part of a mesencephalon and forming the circle of Willis here. Middle cerebral artery. Right? Again, I have written the answers already. I don't know why I missed that, but this is a temporal window. Mesencephalon, right? This is not the cerebellum. This is a part of a mesencephalon, and that's where you see the circle of Willis. Right. Slide with the question again. So this was a term-born baby and was struggling with the breathing, got intubated, ventilated, and this is the image of the head ultrasound, just the 2D followed by the Doppler on this both these sections here, cuts here. And just to give you a comparison with how the normal looks like. So this is the normal, this is how normal looks like. So can you tell me what it is? Any guesses here?
Sorry? Malformation of the veins, a malformation. Vein of Galen, maybe?
Vein of Galen, excellent. Excellent, that's a vein of Galen malformation. Sorry, this is just a just to see that you all guys are awake and not bored by me. Right, okay. What is this? Any guess?
CT scan machine. Historical.
Yes, I have given a disclaimer. I'm a student of history. I like it. So, can anybody tell me what kind of a machine is this? No? Wild guesses, guys? All right. This is the first MRI scanner. Right? So this is how gross it used to look like. And let me give you a little bit of a history behind the MRI scanner as well. I don't know if people are aware. how the MRI came into existence in the medical science. So it's a direct trickle-down effect from the astrophysics. They have noticed something called as nuclear magnetic resonance, and they use it to study the stars and the composition of stars out there in the cosmos. And some wise people thought, okay, if we can, study the stars, billions of light years away, I'm sure we can do the nuclear resonance of the hydrogen atoms in the human body as well. And that was that's how they conceived the plan to get the MRI machine for use in the medical science. And that's how it looked when they built it up. Right. So again, no guesses. So we are moving to the MRI part of it. As I said, the gold standard is the MRI in terms of prognostication. Cranial ultrasound gives you just the real-time monitoring of what's happening with that baby. MRI gives you brain maturation much more clearly than the cranial ultrasound. And it also gives you information of the myelination, right? Which doesn't happen with the cranial ultrasound. It can detect diffuse and non-cystic white matter injury, which was a limitation for the cranial ultrasound. It can detect punctate cerebellar hemorrhages. Just to be aware, the cerebellar hemorrhage, it is very easily missed. The punctate ones are very easily missed. I have never seen it. I've not been able to diagnose that on this cranial ultrasound. But you can very clearly, crystal clearly see that in the MRI. And there's something called as the DW, the diffusion weighted MRI, and this is the best for the early detection of the HIE injury because it detects the ischemia the best. Why? Let's discuss that. Again, this is the different cuts, the axonal, coronal, and sagittal. I'm sure you guys are expert on this already. But the sagittal sections looks like this. We know that. And that's how the coronal looks like. Axial, you don't do many on the cranial ultrasound except for the mastoid and the temporal views. But it is just, cutting the axial section of the brain. Okay, so terminologies with the MRI. So T1W sequence basically means it means T1W. How do we know? Again, I'm not a radiologist, so I'm not going to spend a lot of time in trying to decipher the physics behind it. But just be aware that when you have a T1 sequence, the CSF is dark. That's how you find out, right? When you have a T2 sequence, the CSF is bright. So that's T1 ventricles, inside the ventricles, black CSF, T1 imaging. Ventricles, white CSF, bright CSF. So that's T2 weighted sequence. The way I used to remember as a medical student is World War II. So, so in World War II, WW2, the water is white. So WW2. So any fluid in T2, water is white. So any fluid will be white in color. So if you see white fluid, then you know it's a T2W sequence. And then you have, I'm not going to spend time on the flare. It's just the fluid attenuated resonance. And because we're not going to use that, so I'm going to skip it. There's a diffusion weighted. So diffusion weighted imaging is basically the principle behind it is about the diffusion of the water molecules, and I'll tell you what that is. So T1 ideal for basal ganglia and the thalamic areas and the internal capsule and the myelination. So all these are best depicted in the T1 images, and you can see this bright white line bilaterally adjacent to the hypo kind of echoic. That would be the wrong word, but the grayish area. So this is the part of the caudate, and the white lines are the internal capsule, the posterior limb of the internal capsule. Just be aware, fat is always bright in T1 and the fluid is always dark. So it's like a normal anatomy. The gray matter is gray and the white matter is white. Posterior limb of internal capsule should be white in T1 weighted image. If it is a T1 weighted, you don't see a bright line, that's a problem, right? Again, just showing you the normal anatomy here. So that's your ventricle coming to caudate. The white line here is your the posterior part is the posterior part of the internal capsule, but that's all the tracks coming from all the way from the cortexes, and then the lentiform nucleuses. Again, the schematics are the same. This is how it looks. The lentiform nucleus, head of the chordate, thalamus, and the internal capsule. And this is the posterior limb of the internal capsule. And as I said, where is it? So the fat look bright. You can imagine, the internal capsule is full of myelin, and the myelin sheets are made up of fat, the lipid molecules, right? So because it is full of myelin, full of fat and lipid, it looks bright on the T1 weighted images. Absent signal intensity in PLIC in HIE. So that's the normal, right? So that's normal intensity, the bright white line. But when you see on the image on your right, you can see there's an absent of the, let's remove that. Yeah, so you can see bright white line, internal capsule, which you can't see on this one, right? So this is a baby, term baby, see extensive gyral ensulcation. So term baby, slit-like ventricles, and you cannot see those white lines over here, right? However, you can see increased density, echogenicity, or the brightness of the chordate nucleus, right? And the lentiform nucleus, the thalamic areas. But you don't see this bright line here. Okay, how the T2 images looks like. So T2s are best for gray-white matter differentiation in preterm babies. Forget about the T, E, and TR times. It is out of the scope of this discussion. But when they employ longer T, E, and TR times, the fat looks darker and the fluid looks brighter. And this is all to do with how they are interpreting the resonance image from the received by the receiver. So the fat is dark and the fluid is bright inside the CSF. Inside the ventricles, you can see the white CSF. Diffusion weighted MRI. As I said, it is the basic principle is the diffusion. So you can imagine when you drop a drop of ink in a glass of water, this is how ink starts dissolving, right? And eventually it colors the entire glass of water. Make sense? So when you're doing diffusion weighted MRI, what it is looking for is, the cells are bounded by the cell membranes, right? So when you have an ischemia and there's an injury, so the cell membranes disrupts, okay? So the diffusion becomes, the inside of the cell content comes out, there's an inflammation, and there's a diffusion of water there, all right? And that's why there's a, edema swelling over there. So as soon as ischemia happens, so diffusion weighted MRI, you can imagine, will give you the best result, or it'll give you the earliest detection of the ischemia in the brain, just by looking at how the water molecules are diffusing across the cells. Making sense? I hope it does. So it measures the movement, something called as a Brownian movement of water molecules. What is Brownian movement? It's a random movement of the water molecules. That's it. So water can move randomly anywhere. It is bounded by the cells. So by our cells, so it stays inside the cell. That's how the normal T1, T2 MRI looks at it. But when there's a disruption, it can come out, it can go in, and this coming out and going in is that the detection of that movement is done by the diffusion weighted MRI. So ischemia, decreased diffusion. This is the best modality for acute ischemic injuries, also in the cases of infarcts. And you can imagine, because the diffusion will be limited or facilitated by either the intact membrane or the breakdown of the membrane. The other uses will be infection, inflammation, and also hyperglycemia, where the integrity of the membrane is disrupted. Normal term MRI, so T1, nice PLIC, posterior limb of internal capsule. How do I know it's T1? The CSF is black and the bright and posterior limb of internal capsule. T2, how do I know it's T2? Look at the ventricles, slit-like ventricles. and again the posterior horn of the lateral ventricle. And then you can see the plic as a black line here. It's opposite, right? And this is a diffusion weighted imaging of a normal term infant. You can't see any changes here because there is no infarct. If you have seen, if there had been any infarct, that area will brighten up like a bulb. How the increased signal intensity of the BGT looks like. The BGT, again, basal ganglia and thalamus. So you cannot see any plic here, but the intensity of the basal ganglia area has gone up. So it looks quite bright, right? Again, quite bright. Again, similar picture, brighter here. Forget about the arrow, it's depicting something else, but this is what it looks like. So increased signal intensity of the basal ganglia and the thalamic areas when you have a HIE. Right. And 50 to 70% of the infants with the HI will always have the basal ganglia thalamic areas injuries. Oops. Right. Anybody wants to comment on this one? What we are seeing? First of all, is it a T1 or a T2 imaging?
T1.
Excellent. So this is T1, not T2, because the CSF is not bright. And in A, you can see a nice bright white line, so posterior of the internal capsule, right? Can you see any of this here? We can't see any of this thing here, right? Can't see any of this thing here. Oh, Kun. Oops. What happened? Alo, can you still see my slides?
We can see you, can't see your slides. So you might just have to share again.
Can you see it now? No?
No.
Just bear with me, Alo. Can you see now?
No.
Now?
Yeah, now we can see.
Lovely. Sorry about that. Right. So we were here. Yeah. So anybody wants to comment on this one, this particular image? B, C, and D.
In B,
Anybody?
we cannot see that posterior limb of internal capsule. That's
Posterior limb of the internal capsule. Yeah.
is not
And
visible.
can you see the markings? So loss of differentiation, right?
Yes.
Yes. Can you see the ventricle squished? Kind of a midline shift. Yeah. So that is again because of the edema. This is again another baby. So this is quite an extensive one. And the image, the B image, quite an extensive swelling, inflammation. You can see the ventricles are barely there, squished, midline shift. You cannot make out any gyral and circle markings except for these lateral areas. So quite an extensive cerebral edema here. In C, you can see the ventricles are all right. You can see the cabum as well, but yet the intensity has gone down for the plic, right? Everyone agrees? So the edema is not that bad, but your the hit has been taken by the internal capsule, so the brightness has gone down. This is again kind of a fuzzy brain kind of an image. No plic. You cannot see the posterior of the internal capsule. Again, not massive edema. It's just the plic has taken the hit. Agrees? Right.
Yes.
So. Right. So this is a case, a day 4 MRI of a term baby. The baby's name was baby Elon Trump. And Anybody like to, have a go on the images?
So first one is the T1 image.
Yes.
Here we can see the ventricles and the gyri, but the plic is not very well visualized.
Excellent.
So that is gone. And the second one is the T2 image. So in the T2 image, we can see that the next to this thalamic region and all, there is some hypoechoic areas less.
So that is the plic looks hypoechoic in T2. You can see some remnant of it, but you clearly can't see any plic in the T1. Yeah. So you can imagine, this baby had taken a hit, and there was some involvement of the cortical areas as well. That's why I, given the name of a baby's name as Elon Trump. So this baby progressed to second week scan, and you can see any comment here. T1, T2, and the arrows. Any comment on the arrows? So this is not plic. Again, this is not plic. So this is the hyper echogenic basal ganglia areas and thalamic areas, right? It should be hypoechoic. The brightness, there shouldn't be brightness like this in the caudate nucleuses or the thalamic areas, but that's what you can see. So it has evolved by the second week. The injury has evolved. So this baby was cooled, and you can see the changes in the basal ganglia and the thalamic regions, and similar changes here as well. This particular area getting brighter. Oops. Brighter in the T2 imaging. So the the thing to remember in the MRI with the HIE, we are focusing in this particular watershed areas. You're looking for the plic. The plic should be bright in T1. It should be hypoechoic in T2. You're looking at the basal ganglic thalamic areas. Those should be hypoechoic in T1 and opposite hyper in T2. And that's what we're looking at. And you do focus on the cortical areas as well, right? And the changes would be similar. What is wrong here? Anyone?
Similar, the plic is not.
Right, I'll
be
give you the
seen.
answer. So it's a T1 brain, and there's an arrow. What's happening in the place of arrow? I have just, and there's just one arrow here, but there's ideally that should have been two arrows. But there you go. This is the area.
While bilaterally, you can see that the areas of basal ganglia thalamus, that is more echoic than the, ideally it should have been plic, but it's not the plic, it's the basal ganglia thalamus areas which are more echogenic.
Yeah. So excellent. So that's what it is, right? And to be honest with you, this is not a case of HIE, but this is a case of the conditions which masquerade as an HIE. So the most common condition which masquerades an HIE is hyperglycemia. So all there again, you lose your plic. So when you lose your plic, you think of this, and these babies do behave actually like HIE babies with seizures and whatnot. With the abdominal neurology. So this is a case of a hyperglycemia, right? Metabolic syndrome. But then that's why they are called the great masquerader of the HIE or the mimicker of the HIE, because you don't see the plic, and you think of it as a could be a case of HIE, right? Makes sense. Cool. What is going wrong here? Again, I'll give you the things. T1, black CSF, head, of course, and then
Looks like a fuzzy brain again. It's very
yes,
poor gyri and sulci delineation. And we can see some white spots underneath the, I don't know what that is. We can see somewhere closer to the
hyper intensity. Yeah,
yes.
there's a hyper signal intensity there. Yeah. Again, focusing in this area, what you can't see in a T1 image.
Can't see the plic again.
Excellent. So that's what we are looking for. So this area, I can't see the plic. All right. So focus here, look, try to find the plic, and then look for the basal ganglic areas. There is no hyper-echogenicity of the basal ganglic areas, but definitely you can't see the plic, which has become basically hypoechoic, right? And that's all I want you to remember in terms of the MRI. None of us are neuroradiologists here, and we won't be able to decipher everything, but this is the most important thing to look at the in the MRI scans when we are dealing with the HIE. Similar, all this while we have spoken about the T1. So this is the same baby, the one which we have talked in with the T1 imaging. Now this is a T2 imaging. In the T2 sequence, the plic looks hypoechoic, loss of differentiation, edema, so midline shift. Again, you can see a remnant, slightly remnant of a plic here, but nothing more, and that's a diffusion image. So T2 sequence of the same baby which we have just discussed. It just becomes opposite of the T1 sequence. All right. Loss of gray-white matter differentiation, and this doesn't need any explainer here. When we say gray-white matter differentiation, just look at the gray-white matter differentiation normally in the other babies, like that's the normal one. So gray-white matter differentiation, you can see the rims and the white matter here, right? You can clearly make out the gray and white matter, right? You can clearly make that out. But when you come here, when we say the loss of gray-white matter differentiation, just look at it. You cannot make out anything except for there is some remnant of the ventricles here. Extensive cerebral edema. You cannot make out any plic here. Same here. Forget about the third image. That's a diffusion weighted imaging here. So just forget about the third one. But just when I say loss of gray-white matter differentiation, this is what I mean, right? It has become fuzzy. So this is the price question. Anyone?
Is showing the
right. So T1 you cannot see much.
T1 you can't see much, but in the diffusion image you can see the infarct.
Yes, you can see in the diffusion image, it's brightening up like anything. So flare is also kind of a diffusion. So flare and the diffusion, right? And I told you that if there's an ischemia, then you will see that it bulb, light up like a bulb. So that's what you can see here. You can't make much in the T1 unless you have an eagle eye. T2, maybe I would not able to make that out, but nobody can miss this, right? So this is a unilateral MCA infarct. All right. And this is just to show you, nothing to do with the HIE, but this is just to show you that it lights up like a bulb when you run the DWI sequence, because this area is not taking part in any diffusion, and that's what the MRI picks up. Okay. Anybody knows this guy? No. So he's an astrophysicist called Neil deGrasse Tyson, and he's written a lovely book called Astrophysics for People in a Hurry. The reason I'm showing you this is I've discussed to you already. This is how we have conceived MRI for medicine. It has come from the frontiers of the science in cosmos. So they used to study the stars. Not been there, but they know what it is made up of by employing something called as spectroscopy. So that's what we do in MR spectroscopy. We try to measure the metabolites. So Na, choline, creatine, and lactate. Very simple concept. So if you have a rupture of the cell membrane because of the ischemia, edema, you're not getting enough oxygen to run your aerobic metabolism. So what happens inside the cell? You're not getting enough oxygen, anaerobic metabolism. Anaerobic metabolism, your lactate goes up. Normal pattern in turn, that's term neonates, that's the lactate level. Look at the HIE babies. When you move the voxel towards, the voxel is this area of interest. You put it on the BGT area and you can see high level of lactate, and Na has gone down relatively. So lactate has become much higher than the Na.
Abhijit, we have 5 minutes.
Just 5 minutes. Yeah, I'm nearly done.
Okay.
Right. So so this is what the spectroscopy does. So you can look at if the lactate levels are very high. Brain is not the area to have an anaerobic metabolism. So if you have anaerobic metabolism, your lactate is going to go up because that's an anaerobic glycolysis. If your lactates are high up, that's a case of HIE, right? If you don't see that, with the great masqueraders, you might not see you don't see the plaque, but you go and put it down, your voxel, the area of interest there, and you don't see that lactate peak. Rather, you will see a glycine peak. That's how you know, this is not actually HIE. This is actually hyperglycemia, right? No, we can't see the plaque, but we can make the differentiation with the spectroscopy, right? Again, in the interest of time, I'll take the fun away. So these are the ultrasound images, the earlier ultrasound images. Nobody can read it, neither I am. Neither I can read this one. So it's a A mode ultrasound image. So maybe whenever next time we meet, I can tell you what they're trying to do here. But just know that this is an ultrasound image. The first time when they were trying to do the A mode ultrasound. Of course, not of the brain, but ultrasound. So predicting outcome. Pattern of the injury dictates the neurodevelopmental outcome. If your basal ganglia or the thalamic lesions are involved, there's lesions in the thalamic areas. They are, 70% of the time associated with cerebral palsies. Abnormal plic signal intensity is always associated with abnormal motor outcome. Why? No wonder. The plic is carrying the fibers from the cortical to the to the midbrain and all the way to the spinal cord. If there's a problem there, you're going to have a motor problem. And then brainstem injury has the worst prognosis. That's the deepest nuclei is there. So if you have a problem there, that has got the worst prognosis. Recommendations: images between 5 to 14 days. You should always do T1 and T2 weighted images and always do a DW sequence to show the changes of the early acute ischemia. And MR spectroscopy with the lactate NA ratio is always a plus and welcoming addition. Again, if anybody wants to take a guess, this is a normal and this is abnormal. I've told you that already. This is abnormal only on what side? What could be the pathology? You cannot see the plaque on just one side. What could be the pathology? You do not get HIE on one side, right? It's a global involvement. If you have lost the pick just on the one side, that's normal. That's abnormal. Loss of pick on one side. What is your wildest guess? Anyone? Infarct. Right? Unilateral pick and cerebral artery. Yes, that's a stroke. Right? Moving on. Again, these were a few quiz questions. So anyone wants to take a shot? I'm not sure if you guys have gone through.
Once again, can you repeat the question?
I said this is just a trick question. What is this? I'm not sure if you guys have been through all the modules. I'm sorry about that, but I just thought I'll put up the slide and ask the question anyway. This is not the MRI. This is the cranial scan. It's a preterm baby.
There is preterm.
Yeah, preterm baby. Not much of a sulcation, gyration. There's a wide interhemispheric gap. Calcarine sulcus is quite open, and you can see something here. Grade 4 IVH. Right. In the interest of time, I'm just going to skip this, and Alok can take up all this with you in his next sessions. Last one, promise, guys. What is this?
This is total body cooling machine.
I thought so. It is not. This is iron lung. This was used in Boston with the patients of the polio at that point of time. I'll just ignore the rest of it. Just know that this is an iron lung. Before the ventilation, you had the ventilation at the ventilators, so they used to use this because the polio, if it involves the upper body, breathing difficulties and all that. Anyway, any questions? I'll be happy to take that. And this is my team in Glasgow where we do all the scans. We call our team as a team Hocus Pocus. most of the people, they whenever we are by the bedside, we are always with the machine, and they think like, what the heck we are doing with the machine all the time. And so we came up with the name of a team Hocus Pocus. Right. Happy to take any questions.
So we have time for 1 or 2 questions. You can unmute yourself.
Good evening. Thank you so much for your presentation, Dr. Bhattacharya. Just 2 quick questions. One would be regarding the ultrasound cranium. Like, my department does not have an ultrasound of its own, and we don't probably have the liberty to do sequential ultrasounds. So according to you, what would be like the 1, 2, 3? Like, you have to see whether it's a fuzzy brain or see the resistive index. Like, what would be your 1, 2, 3 go-to diagnosis for an HIE? The first question.
Yeah. Okay.
And the second one, very quickly, is it possible to differentiate like a mild, moderate, and a severe, like how you have the staging in HIE? Is it possible to do that on an ultrasound and see whether it's a mild, a moderate, or a severe? Sorry, only those 2 questions.
Lovely. Thank you. Interesting question. Yeah. So, in terms of if I have to give you 1, 2, 3 things to look at, and then the baby suspected of HIE, of course, the first thing I would like to look at with the cranial ultrasound is the resistive index, because that will give me a lot of information of what's actually happening inside the brain at that point of time. Because once you start the therapeutic hypothermia, you won't get much of a meaning out of that. Number 1. Number 2, yes, you can look at the fuzzy brain, the loss of the gray-white matter differentiation. And to be honest, beyond this, it's really difficult to have a look at that point of time, because ultrasound is not very good at picking up the acute changes, right? So in day 1, it won't pick it up. It won't pick it up. In terms of mild, moderate, and severe, there have been some studies to have a look, try to differentiate mild, moderate, and severe in cranial ultrasound, but no, we don't use anything. I'm not aware if Alok is aware if there's anything that we can use to do.
I would kind of just emphasize the importance of clinical correlation and, really use of the clinical course, of how the baby evolves neurologically, because the only thing I'd say, even with MRI, unless you've really got basal ganglia, thalamic, and posterior limb changes, the correlation with neuromotor outcomes is fairly well defined. But other outcomes, there's quite a big variation. So in terms of severity acutely and predicting whether this baby is going to survive or not, no, I'm not sure that ultrasound will be helpful. In terms of long-term prognosis, you need to be able to do serial ultrasound with MRI and really look at the entire clinical picture, the clinical course, multi-organ dysfunction, how the babies responded to cooling therapy, amplitude integrated EEG. It's basically a package. And really, it's this entire package that then brings us to a kind of approach towards prognosis. But clinical examination of the baby in clinical neurology is absolutely crucial. Yeah. Any other questions? I'm going to take this opportunity to thank Abhijit. God bless you, and fantastic talk. I look forward to guys seeing you on Sunday. We will catch up again. Again, those of you who want to do peer review, please just make sure that you put your images into a PowerPoint. It just takes 5 minutes, literally dragging across the images. So, by all means, it just makes things more uniform. So God bless you all. Thank you very much and have a nice day. Thank you, Abhijit.